Welcome to the SSR Resident Education Club webinar series for December 2023, focusing on interesting shoulder cases. My name is Dr. Linda Probin, and I'm a musculoskeletal radiologist at the University of Toronto and Vice Chair of Education for the Department of Medical Imaging. I am pleased to introduce Dr. Maxie Kresse, who will be leading our session today. Dr. Kresse is an assistant professor in the Division of Musculoskeletal Radiology at the University of Virginia. She completed her diagnostic radiology residency at the University of Pittsburgh Medical Center and her musculoskeletal imaging fellowship at Mayo Clinic, Arizona. Dr. Kresse is the current chair of the SSR Residency and Fellowship Education Committee at the Society of Skeletal Radiology. And I will be your moderator for today. And Dr. Kresse has a series of cases that she's going to be showing you, and there will be an opportunity for you to ask questions. We do ask that you put your questions in the Q&A box on your screen, and we will get to those when we can. And Dr. Kresse will also have some audience response questions that you will be answering in the chat, and we will direct you to do that when it's time. At the end of the session, we're going to ask you to complete an evaluation form, and the link will be put in the chat and also will be emailed to you at the end of the session. And just thank you to Veritas for organizing and supporting this webinar series. So thank you so much, and I will hand it over to Dr. Kresse to get us started.
All right, thank you, Linda. Welcome. Thank you for joining. So tonight is interesting shoulder cases. I have 10 cases to show. As Linda mentioned, I do have some questions throughout the cases that if you would like to participate, you can type your answer in the chat box, and that will help guide some discussion. I'm going to go through 7 cases, and then I'll take a break for any questions. And then if we still have time, we can do the last 3. So hopefully everybody can see that now. So interesting shoulder cases tonight. Case number 1. So we have a 75-year-old male, 3-month history of gradually worsening atraumatic shoulder pain. If you know the diagnosis here, you can put it in the chat box. Give people a minute to look at the images. All right, got a couple people on it already. So we have this large globular calcification here projecting over the distal supraspinatus tendon. Here it is. All right, so what should we do next? There are a couple ways to manage this, but does anybody have any thoughts about what we do in radiology? Barbotage, okay. Seeing a couple of the answers here. Okay, so this patient was referred for ultrasound-guided calcification lavage. I'm sure people have a little bit different techniques of what they do, so I'll just go through what we do here at UVA. So this is our initial image of this patient. You see the nice curvilinear calcification, shadowing, nothing remarkable on the color Doppler image. So here's our image here. So after numbing the skin, we put an 18-gauge needle, ideally with the tip right in the middle of the calcium, not through the calcium, because we just want to make one hole, because you want to build up pressure inside of that calcium. And then we do a pumping motion with a 10 cc syringe, combination of saline and bupivacaine. And ideally, you see an image kind of looks like this. See, we call it a fish mouth. So that's what it looks like inside the patient. And then have a video here that you can see outside the patient. So you're doing that pumping motion with your thumb here on the syringe. And ideally, you're getting this nice chalky calcium back in the syringe. And this is what it looks like here. So this image is showing the opaque calcium coming back into the syringe. And then this is just comparing to a normal, like, clear saline. And then if you hold this up, this calcium is going to layer with gravity. So this particular patient, I think we got about 5 of these syringes, and usually the patient, really likes to see them and is feeling pretty good when you show them how much calcium you get out of their shoulder. After we do that, then we do a subacromial subdeltoid steroid bursa injection, which just helps calm down all the inflammation in that area. Okay, so this patient went to clinic 6 weeks later, feeling much better, and then follow-up radiographs showed, so this is our pre here, that large calcium chunk. So 2 months later, this is the post radiograph showing pretty much all of that calcium is now gone. There's just a tiny little bit here. So radiographs and patient both doing a lot better. This is the other view, just that large calcium pretty much completely gone. So as everybody, as a lot of people jumped out at the beginning, so this is hydroxyapatite deposition disease. There are a lot of different names for this. Some people call it calcific tendinosis, tendinopathy, tendinitis, all kind of mean the same thing. Supraspinatus tendon is the most common. Just to review the imaging findings, so on radiograph, we're going to see this nice globular calcification. That's a different patient. Ultrasound, you're going to see this calcification here with shadowing. On MRI, it can be a little tricky because the calcium is dark on T2, dark on T1, and sometimes it almost blends in with the tendon a little bit. So it can be almost a little harder to see on MRI sometimes. You can get edema surrounding it on MRI, and that can limit your evaluation of the adjacent rotator cuff. It can extend into the bone or the bursa. So here I have an example. So this calcium, you can see, is pretty much completely within the subacromial subdeltoid bursa. So this is the radiograph, it's layering within the bursa. Here's your corresponding MRI image. So you see this dark calcium layering within the fluid in the bursa, so bursitis caused by this hydroxyapatite deposition. Okay, so moving on. Let's see, a question here. Do you have any minimum threshold of calcium deposit before offering this procedure? We don't really, but if it's really small, the chances of getting return when you do that pumping action are usually pretty low, but you can still fenestrate the calcium and try and break it up. So even if it's very small, you can break it up more. And so we still do the procedure, just try and break it up more than get the calcium out. And then we can still do the bursa injection, which I think helps people feel better, even if you don't get any calcium out. Okay, sure. Okay, so moving on to case number 2. So this is a 79-year-old female, has a reverse total shoulder arthroplasty, was initially doing well, but then about 2 months later, is feeling like increasing pain with physical therapy. So, started ramping up physical therapy and now having pain. Does anyone have any thoughts? Yeah, I see it there. Somebody's got it. So next step, compare to prior. I feel like if you're taking a case in conference or on an exam, it never is, you probably can't be wrong if you say I want a prior, because radiology, everybody likes to have priors and that can really help us. So for example, on this one, here's our prior. So this is 2 weeks post-op. This is our current 2 months post-op. I'm going to add a few lines here, something that I find helpful on these cases. So if you look at the angle of the acromion, so here's the initial, it looks pretty flat. And then on our follow-up, you can see this kind of sharper angle. And sometimes when you can't see the fracture line, this angle can be a really helpful clue. So this patient, we didn't call it on the radiographs, ended up getting a CT. So now it's much more obvious, as always, on the CT. So here's our fracture line. There's a little callus formation because at this point it's a subacute fracture. So as somebody mentioned here, this is an acromion fracture. This is a common complication of reverse total shoulder arthroplasty because you get the deltoid pulling instead of the rotator cuff. So it's something to always have on your checklist when you're getting these follow-up radiographs. It can be really subtle, like sometimes you don't even see the fracture line, you just see that change in angulation. And the history can be really helpful because patients often do have increased pain, and it's often in that subacute time frame when they start doing physical therapy, they start doing more things around the house, and then they realize, like, oh, I'm actually feeling worse rather than better. So this angle, I think, is a pretty helpful secondary sign. And on these patients, you should have a pretty low threshold to get a CT just because we know it's a complication that can happen. It can be hard to see on radiographs. Okay, next case here. So case number 3. This is a 30-year-old male, left shoulder pain for 4 to 6 weeks, no injury, but he does do repetitive work. So you can type in the diagnosis here if you have it. All right, got a couple answers. Got a couple of variable answers here. There are a few findings, so I think that's probably fair. So I'm showing you here a sagittal T2 fat saturation image, sagittal T1, axial T2 fat saturation. So there are a few findings on these images, so a lot of these answers are correct. First of all, we do have a posterior superior labral tear, which you can see by this blue arrow. So this contrast is an arthrogram, so the contrast extending through the labrum. You can see it's connected to this paralabral cyst, which is in the spinoglenoid notch. And then we have denervation of the infraspinatus muscle. So this is edema in the infraspinatus muscle and mild atrophy. And this is due to compression of the suprascapular nerve. So these are, pretty popular questions about which nerve, which muscle, which notch. So this is the spinoglenoid notch, infraspinatus muscle, suprascapular nerve. These are most often paralabral cysts. And then here's a companion case, since often I think these are the two that are kind of confusing together. So a different notch is the suprascapular notch cyst. So that's what I'm showing here. On the coronal, you can see it nicely sits within this little divot here. And then a trick on the sagittal is to find the scapular spine and just draw a line down your scapular spine. So anything above it is going to be the suprascapular notch, and below it is the spinoglenoid notch. I actually found it pretty hard to find an isolated suprascapular notch cyst. So I think a lot of times it comes with a spinoglenoid notch cyst. But if it involves this space, then it's still the same nerve. It's the suprascapular nerve, but you also want to look at the supraspinatus muscle in addition to the infraspinatus muscle. This patient doesn't have any muscle changes yet, but this one can involve supraspinatus and infraspinatus. All right. So moving on to case number 4. So this is a 40-year-old male, 3-month history of right shoulder and neck pain, no injury, worse 2 weeks ago after installing a bathtub. And the patient, on clinical exam, there was noted to be a mass. Anyone have any thoughts on this one? All right. Got an answer here. Yeah, this is definitely abnormal, right? This is one you look at and it's just like, okay. This is not a lot of it looks normal here. So almost the entire humeral head and neck is gone. You have this surgical-like margin. You have this ossific debris. There's a little remodeling of the glenoid, some subluxation here. This patient came from an outside hospital, and also they sent these MRI images. And here we have an axial stir, coronal stir image. So again, the humeral head is basically gone. There's adjacent marrow edema in the humerus, large joint effusion. It extends into the bursa because this patient has massive rotator cuff tears. So based on these findings, a couple of people seem to be onto the diagnosis here. So I saw it mentioned once already that our next step. So when you see this, you want to have this diagnosis in mind and recommend a cervical spine MRI. So this patient, here's the axial T2 image, sagittal T2, and this is a pretty impressive syrinx. It extends all the way from C1, it went all the way into the thoracic spine. And on the axial image, this blue line is showing the level of the axial image, and so you can see it takes up a decent diameter of the cord and kind of explains why this patient is having symptoms. They also have herniation of their cerebellar tonsils here, so they have a Chiari-1 malformation. So as some of you mentioned in the chat box, this is a case of neuropathic arthropathy. It's also called Charcot shoulder. The buzzword that you'll hear associated with this is surgical margin. And so that's when this looks very sharp and like it was just cut. And so surgical margin is kind of the buzzword for this neuropathic arthropathy. This patient also had some remodeling of the glenoid and this ossific debris. On the MRI, you'll often see these large effusions, massive rotator cuff tears, and again, that bone resorption. So about 25% of patients with a syrinx will develop neuropathic arthropathy, and most of those are in the arm. Your differential diagnosis on a case like this is going to be, you always want to kind of have infection in the back of your mind, so septic arthritis, osteomyelitis. But these, it looks a little less acute because it's more smooth here. I think you could argue that the margin of this looks a little bit more acute, but overall it looks more of a long-term process than a rapidly kind of progressive infectious process. And then Milwaukee shoulder is the other one that can have this look. Usually it's less severe than this in terms of the amount of bone resorption, and it's also less common. So if you see this look, it's definitely a good idea to make sure the patient gets a cervical spine MRI. Okay. Case number 5 is a 72-year-old male, progressive shoulder pain, stiffness, decreased range of motion. Anybody have any thoughts here? I'm giving you sagittal proton density, fat saturation, sagittal T1, coronal proton density, fat saturation. Okay, nice. Yeah, I'm getting some answers here on target. So some findings here that we're looking at on MRI. So on your sagittal, you see edema and loss of fat in the rotator interval. You also have thickening of the coracohumeral ligament. So this image is showing the coracohumeral ligament is very thick. You have thickening and edema of the joint capsule or the axillary recess. So here's all this edema and thickening. For people that haven't looked at as many shoulder MRIs, I have our patient on the top row and then a normal on the bottom, just to show the difference in these findings. So it's not areas that you often focus on necessarily. So this is the patient with the finding here with edema and thickening of the inferior glenohumeral ligament here. This one is normal, so it should be black and thin, like in this patient. Moving to the T1, this patient, the normal one, has nice preservation of fat within the rotator interval. You can see the difference in the coracohumeral ligament on how thin it is here versus this patient up here is super thick. And you also have a lot more fat in the rotator interval on this normal MRI. And then this one, the difference, just showing that edema and thickening versus what it should normally look like, just normal suppression of fat in that area. So this patient came in for a steroid injection, and if anyone's tried to do an injection on somebody with adhesive capsulitis, it can be kind of more difficult than your usual injection. You can get some resistance, and sometimes you can't get very much into the joint. This patient, initially it all went in the superior subscapularis recess and then kind of went around here, but there was a decent amount of resistance with injection and then eventually loosened up. So as some of you have already mentioned, the diagnosis here is adhesive capsulitis. This is also called frozen shoulder. Patients will have decreased range of motion. It's more common in diabetic patients and after trauma or surgery. MRI, the findings are going to be that rotator interval edema and loss of fat, coracohumeral ligament thickening, and the edematous joint capsule. When you try and do an injection, these patients can have resistance and a low volume capsule with injection. Okay, case number 6. So this is an 88-year-old male, history of a prior shoulder dislocation about a year ago. Been doing well until about 2 months ago, had worsening shoulder pain and swelling. So these are radiographs. These are abnormal radiographs, but this is all chronic. So a acromial-humeral interval is narrow, probably related to a chronic rotator cuff tear, had an old fracture here, the greater tuberosity, some remodeling here. But these were all the same as his prior radiographs, didn't really explain his new pain and swelling. So this patient went into clinic, and given that they were worried about potentially some sort of swelling, maybe infection, they tried to get an aspiration of the joint from a posterior approach, didn't get any fluid. Since the patient was having pain, they gave a steroid injection. But then after that, the patient did not get better, actually got worse. So they decided to send the patient to radiology for a subacromial subdeltoid bursa aspiration. And they wanted to get fluid analysis because the inflammatory markers were up, and just make sure there's no infection, abscess, anything else going on. So patient comes into radiology. Here are the initial images. So this bone is the humerus. You can see at the bottom of the screen, there's not a lot of landmarks here because the patient did have full thickness rotator cuff tears, which were chronic, but you do have all of this in the subacromial subdeltoid bursa space. So anyone have any thoughts on the next step here? Yeah, a couple of mixed answers. So if you're about to do a procedure, one thing you definitely always want to do, which somebody did comment on in the chat, is you make sure to check color. So this makes you glad you turned on the color. Anyone have any thoughts now on what the diagnosis is? Okay. See a couple of them there. Okay. I'll give you some more imaging here. We'll see if this helps. So a couple of people are onto it. So you have this patient in your clinic, and it's Friday afternoon. And you see this on ultrasound. So what are we going to do next? So first, yeah, a couple of people got it here. Number one, we cancel aspiration, right? No aspiration for this patient. Next, we did send the patient to the ER, and somebody actually already mentioned it here, but the ER likes to get CTs. So first, we got a CTA. They get same findings as on the ultrasound. Here's the humerus. Here's your feeding vessel. Here's the sac, hematoma around it, feeding vessel, sac, hematoma. Interventional radiology. Here's your pre with that same feeding vessel, sac, pre-thrombin, post-thrombin, no more color flow. So as some of you already mentioned, this was a case of a pseudoaneurysm. Number one lesson here is to always turn on color before you do an ultrasound guided procedure, especially before you aspirate a fluid collection. Just to review the ultrasound findings here. So the first image that we looked at is the yin-yang sign. So that's the blood flow within the cystic structure, that swirling motion of the bidirectional flow. This is your feeding vessel here. And if you put the spectral Doppler over that feeding vessel, you should get this to and fro waveform, which is blood entering the sac in systole and leaving during diastole. The CTA showed, kind of the same findings, that feeding vessel filling the sac, and then this patient did have some adjacent hemorrhage. So that was a pseudoaneurysm. Okay. Case 7. So this is a 47-year-old female, had a fall 9 months ago, continued pain, physical exam found a knot and elevation of the clavicle. They also mentioned a bulge in the deltoid muscle. Does anyone have the diagnosis here based on these images? Okay, I'm going to give a couple. Correct on the AC separation. That is the main finding. But that was similar to prior, and there's something else. There's another reason I'm showing this. Definitely AC separation. Anything else? See a couple of people, yeah, trying to account for the bulge in the deltoid. There is some soft tissue fullness, yeah. Soft tissue mass, we're getting close, yep. Focus on the humerus here. I'm gonna add some arrows. Okay. Yeah, so something more aggressive now, right? Based on this. Okay, so nothing was mentioned on the radiographs except for the AC separation. So luckily we ended up getting an MRI for preoperative planning, and here's the MRI. So we do have this AC joint finding, but the bigger finding is here. More importantly, we have this huge marrow replacing lesion, large soft tissue component. A few of you seem to notice that the deltoid was bulging out and something was abnormal there. Somebody's got it here. So this was only partially imaged because this is the shoulder MRI for the AC joint separation. So we got a dedicated humerus MRI. And I'm giving you all coronal images here. So T1, post-contrast, and STIR. And complete replacement of the marrow and the proximal humerus. This large soft tissue component, which has pretty good heterogeneous enhancement, right on STIR. You can see that the cortex is actually relatively preserved given the size of this large soft tissue component, and that's why I was pretty subtle on the radiographs. And that's what's kind of tricky about these type of tumors. So this, a couple people already mentioned it. This did turn out to be a Ewing sarcoma. This was an ultrasound guided biopsy, but just showing some images here of this large heterogeneous mass, hyperemia. This is our biopsy needle. So Ewing sarcoma. This is one of the small round blue cell tumors, and it is typically in patients 4 to 25 years old. So the age of this patient was unusual. This patient was a little older than you will more commonly see. The lower limb is also a little bit more common than the humerus, but the humerus is not an uncommon spot. So on the radiographs, you can see a permeative appearance or periosteal reaction. I think in retrospect, you can see that cortex is abnormal, but definitely not as abnormal as the MRI. And so if you see this large soft tissue mass with relative sparing of the cortex, think about these small round blue cell tumors like Ewing's or lymphoma. And the other lesson of this case is to be wary of satisfaction of search. So this patient did have the AC separation. That was the diagnosis. They were planning to do surgery for that. So when you see on radiographs, oh yeah, AC joint separation, then just kind of move on, but just try and remember to look around at everything and make sure there's nothing else on the images. Okay, so recap here. Hydroxyapatite deposition, be able to recognize it, and lavage can be an effective treatment option. The acromion fracture, just be sure to remember it, have it on your checklist for a reverse total shoulder arthroplasty and low threshold for CT. The nerve entrapments, just be sure to know your nerves and your muscle that are innervated by those notch cysts. Neuropathic arthropathy, remember the cervical spine MRI. Adhesive capsulitis, just remember it as a cause of shoulder pain. It can make your injection a little bit more difficult. Pseudoaneurysm, always check color flow. Ewing sarcoma, be wary of satisfaction of search. Okay, if people would like to ask questions, I can definitely answer some questions now. We have, I think, about 10 minutes. I also have 3 more cases, so feel free to ask any questions. If we don't have questions, I can keep going.
I don't see any questions that you haven't answered in the chat, and there's nothing also in the Q&A at the moment. Dr. Kresse,
Okay.
can I just ask you one quick question that I have?
Yeah.
Just going back to your very first case of the hydroxyapatite deposition case, when you're doing the barbotage or the lavage, it can be quite painful in my experience for patients. And do you do anything? Do you counsel them ahead of time? Do you inject some steroid, or how do you prepare them for that?
Yeah, that I found that to be the case as well, that people are pretty uncomfortable sometimes. we just give them a lot of lidocaine, and we do say that this can be uncomfortable. I think people start feeling better when you pull out calcium and you kind of say like, oh, we're getting it out, we're getting it out. But I agree, it can be painful. We do the bursa injection afterwards, which I think, helps people feel better, and that's mixed with bupivacaine. But during the procedure, I agree that it can be pretty uncomfortable. Do you guys do anything?
Same, exactly the same thing that you do, just to kind of prepare them for it, and just so that they understand that that's normal to have increased pain afterwards, because you don't want them to be shocked that that's going to happen. So we just kind of prepare them. Also, we do the steroid and lots of lidocaine as well, and reassurance. Yeah.
Yeah, and yeah.
I'm not seeing any other cases here. We do have
Yeah.
some time left if you wanted to show maybe 1 to 2 more cases.
I can keep going here. We'll show a couple more. All right, let's see. Here. I can go I can go through these. These are a little quicker here. So case 8, 56-year-old male, shoulder pain for 1 year, had a prior shoulder surgery 7 months before. Give you guys a second to look at these images. Compared to that neuropathic one, this one has kind of some erosions, both sides of the joint, that look more acute appearing. You have erosion at the humeral head, the glenoid, permeative appearance of the bone here. The MRI on this case had a large joint effusion, synovitis, extending through rotator cuff tears. You can see the marrow is very abnormal, bright on T2, dark on T1, has some enhancement, a lot of osseous erosions. So this one is a case of, so they did do surgery. They put in this antibiotic spacer, ended up with the arthroplasty. So this is a case of septic arthritis and osteomyelitis. So the things you're looking for is osseous destruction and erosions on both sides of the joint. It can appear pretty aggressive, and usually the clinical history can be helpful, kind of steer you towards infection. Talked about this. Okay, so this case, number 9, is a 74-year-old male who had a ground level fall. Did have a fracture here, so fracture greater tuberosity, surgical nick. These are initial radiographs. Patient 1 month later, looking like they're healing, not a significant change in alignment. About 9 months after the injury, I think the fracture is still looking pretty good, healing. Anything else that you guys noticed that might explain why this patient is still having pain and soreness, lack of improvement with physical therapy? Any difference you can see from the 1 to the 9 months? Yeah, got it here. So sclerosis here. Yep, people getting it. Here's the MRI. So you have that double line sign. So this is your T2 image. You have your bright line, your dark line. T1, you're going to see preservation of fat within that area, your double line sign on your T2 image. So this is a case of osteonecrosis. This can occur after traumas. In this case, can lead to articular surface collapse or secondary osteoarthritis. Radiographs, you're looking for that sclerosis, sometimes mixed sclerosis and lucency, and it can be pretty subtle, so it's just something to keep in mind and have on your checklist to look for. Okay, and then the last case, she may as well get through them since we made it this far. So we have a 55-year-old female with right shoulder pain, no injury. So these radiographs, so take a look in this series and see if you find anything remarkable. All right, somebody's already got it, I think. All right. So we didn't say anything, we just said some degen. So physical therapy, come back as needed. Same patient a year later now has left shoulder pain, this time had a fall. Still get the finding on this image, but this was just read as negative, just little degen. This patient actually has a subtle fracture here, which is seen a little bit on the MRI here, this dark line here with surrounding marrow edema. So that can be a very subtle place to look for fractures, just as a bonus in this case, but not why I'm showing it. Somebody already found it here. So there it is. Reminder to look at the corners or the lungs on shoulder radiographs. So we caught this multiple times, both shoulders, the left shoulder, unfortunately here includes the right lung, or fortunately, depending on if the person saw it or not. But going back to the initial radiographs, here it is. This patient ended up getting a chest CT, biopsy showed adenocarcinoma. Fortunately, they didn't have any mets on the PET CT at the time of the diagnosis. So just to recap those last three, septic arthritis, osteomyelitis, is really important to recognize it early. Osteonecrosis, just keep it in mind on shoulder radiographs. I think, we think about it more on the hips, but remember to look for it on your shoulders as well. Lung adenocarcinoma, just a reminder as radiologists to look at everything on the image, and that's usually the lungs on the shoulders. That's all the cases, so just a couple references. And thank you very much. Appreciate everybody logging in and spending time on this evening to listen to these cases.
Thank you so much, Dr. Kresse, for the amazing, really bread and butter cases, lots of variety of imaging modalities, et cetera. There are actually just two quick questions I'm hoping you can answer in the Q&A. So the first one is, what classification system do you use in humeral fractures?
We don't use any classification, really. We just describe from the labor radiology side, we describe where the fracture is, what part it involves, how displaced the fragments are, the angulation. I find sometimes that if you try and classify something and it doesn't quite fit what the orthopedic surgeon wants to classify it as, it can make it a little complicated in terms of the procedure they want to do or not do. And so I think, describing the parts of the classification systems is the approach that we take, and just make sure you include the parts of the system, but not necessarily giving a number or a grade of different systems.
Mm-hmm. Great. Yeah, we have it's probably worthwhile knowing about the NEAR classification system, but we do the same thing. It's more of a descriptive report. One more quick question. In adhesive capsulitis, if only inferior glenohumeral ligament thickness is 4 millimeters, is that enough to diagnose adhesive capsulitis?
Adhesive capsulitis is one of those subjective diagnoses, I think, on a radiology standpoint. And you find a lot of variability. I think the fellows kind of joke with us, like, I just leave it in there and you guys, because everybody will say something different about it. I think the case I showed is a classic case where you have all of them. And I think that 100% of the time, people are going to say this is adhesive capsulitis. But if you just have one of those findings, or, the fat is a little bit lost in the rotator interval, I think it's very variable if people mention it or not. You can always say this can be seen with adhesive capsulitis. If it fits with their symptoms, it probably fits. I don't think anybody's going to come say you're wrong. This is not adhesive capsulitis if it has, one of those findings. So I don't think it's wrong to say this can be seen with adhesive capsulitis, but there is a lot of variability in that.
Great. Thank you. And that's all the questions we have. I just wanted to thank you once again, Dr. Kresse, amazing cases, getting lots of comments in the chat here, which I don't think the participants can see, but really thanking you for your cases and for your time. And I just want to also, again, thank Veritas for supporting this webinar series. And you'll see that the link to the evaluation is now in the chat. So if you don't catch that, you'll also receive an email, so you can please complete an evaluation. We'd love to hear how we did tonight, and also obviously we want to continue to improve these sessions. So again, really thank you for your time, and hope you have a great rest of the evening, and good night.